Bismillah ar-Rahman ar-Rahim. Congenital heart disease is a very important topic in pediatrics, and today I'm going to talk about murmurs. To start off, I want to read off definitions. A murmur can be defined as an auscultatory because it is something that you have to auscultate with a stethoscope. It's an auscultatory sound, particularly a periodic sound of short duration of cardiac or vascular origin. The thing that I do want to focus on in this specific definition is cardiac or vascular origin. And that gives me an idea because a lot of the murmurs are actually vascular rather than cardiac in origin. But where do they usually come from? They come usually from valves. This is the most important origin. And what are the things that cause murmurs to come? Those would be stenosis. And of course, as you might have already guessed, regurgitations. But to further go on more and talk about murmurs, there are things called innocent murmurs, also known as physiologic murmurs or functional murmurs, murmurs that indicate no pathology. If you think about it enough, you should understand that that means there is no anatomical derangement of any sort. So if you ask yourself, where can I have innocent murmurs? Well, you should be able to tell. One, it could be vascular in origin, especially with exertion, with a little bit of constriction of certain vasculature, or during the development of the heart, which means at birth and soon after. Innocent heart murmurs are sound made by the blood circulating through the heart's chambers and valves or through blood vessels near the heart. So it is due to the circulation mechanism rather than anatomic problems. And of course, they have the two names that I've just mentioned. Before I talk about a few things that make things clear, such as the fetal circulation, the development, and the transition between fetal and adult, which is contrary to what a lot of people think, that there is an immediate transition. There's actually a process happening, and that process can be the cause of innocent murmurs, as we will talk about in a bit. So let me tell you how you're going to approach murmurs. First of all, this is a clinical lecture, so I want you to think, how am I going to approach my patient? Clearly, it's going to be history and physical examination. And the most important tool is going to be auscultation, because as we defined murmurs, they are auscultatory sounds. So the first thing we're going to do is the general exam. The general exam is going to give me an idea. I'm examining a little baby, and I'm going to look for dysmorphic features. I'm going to note if this baby has prematurity, because prematurity is related to atrial septal defects. And of course, it means a delay in the transition between the fetal and the adult circulation. That means a prolonged period with which the ductus arteriosus is patent, the ductus venosus is patent, and so on. A delayed period before there is a closure of a possible atrial septal defect. And I might want to note right here that you know how many children have small atrial septal defects and it doesn't close until later? They're sometimes incidentally found, and the parents are reassured and they're given an appointment to come back at 6 months or so to see whether it closed normally, or then it might need an intervention. Well, the thing is, some people take longer time to transition between fetal and adult circulation. And although we call it pathology to that specific baby, if it closes spontaneously early in life, like at 3 months, 4 months or so, that could just be the physiology of that specific baby. Carrying on, the physical examination, noting dysmorphic features, noting prematurity, noting any possible infections, any possible syndromic features, and then we're going to go to the specific exam. And guess what? That will be auscultation. And when it is auscultation, you're going to be listening for murmurs. And here is the key. I'm going to associate with whether my child is symptomatic. I mean, obviously, during my exam, I'm going to see what symptoms the child is having. And those symptoms are most importantly tachypnea, cyanosis, and of course, tachycardia. And I'm going to associate those symptoms with what I'm hearing. Because, as I said, hearing a murmur per se is not a screening for whether the child has a congenital heart disease. I have to first of all, and before I go into anything, identify whether this child has an innocent murmur or not. So there are steps that we can take, and those steps are as follow. Let us go for step one. For step one, I'm going to be looking at whether this child is symptomatic or asymptomatic. And in one of my children, let's say the child is symptomatic. What are the symptoms? Any combination of tachycardia, tachypnea, and cyanosis. These are the most important symptoms. What other symptoms are there? Agitation or somnolence. The child is overactive or doesn't have energy to. What other symptoms are there? Well, we're going to also make a note of the APGAR score at birth. We're going to make a note of how the child looks like. Does the child look like they're in distress or not? And that is related to the symptoms we said: cyanosis, crying, agitation, somnolence, and so on. Or we're going to see if the child is asymptomatic, no symptoms. As you might have guessed, on the left part here, this is innocent, and on this side, these are pathologic murmurs. Okay, so I have symptoms, or let's make it even harder. I don't have symptoms, but I still am not sure this is a pathologic or an innocent murmur. So I have to go on to my second step. These are steps in exam. These are not screening criteria. These are not diagnostic criteria. I will see the timing of the murmur. Is it systolic or is it diastolic? And if the timing is diastolic, any form of diastolic murmur is going to be pathologic. Question is why? Well, because think about it. Where am I going to have a diastolic murmur? I am having transition in the systolic. I have a ductus arteriosus that's going to close. I have a systemic circulation that was low resistance and it became high resistance. So systolic might be innocent and might be pathologic. But if I have diastolic, then I'm going to go ahead and say there is a pathology. Where can I say a systolic is pathologic? Any systolic could be pathologic, so we have more steps to go through. But it's nice to know that pansystolic is also a pathology. You're not going to have a pansystolic and a consistent murmur that's going to be innocent. Let's go on to the third step in grade. For systolic murmurs, only systolic, by the way, we can give them grades from 1 to 6. The first grade would be, just audible with proper exam and a lot of experience. And you have to be a cardiologist most of the time to be able to even elicit that finding. Grade 2 would be a quiet but readily audible sound with experience rather than a very difficult sound to hear. So it is quiet, but it's there. With a good stethoscope, you should hear it. You don't have to be a cardiologist. Okay? Grade 1 and grade 2, they give us an idea that there isn't really a big problem because they're very quiet sounds, and especially if they're not pansystolic or diastolic, I'm going to go ahead and classify them in the innocent. Grade 3, I'm going to put it at the junction. It could be innocent and it could be pathologic. It's a readily heard sound with a stethoscope. It's easily heard, actually, with a stethoscope. Anything above grade 3 is pathologic. Grade 4, grade 5, and grade 6, and of course, in part, grade 3 itself. Grade 4 would be obvious murmur. with a palpable thrill. Grade 5 would be very loud murmur and heard only with the edge of the stethoscope on the body. And grade 6 would be an audible murmur without even placing the stethoscope on the body. It comes close and you hear the murmur. It's very clear. Those are pathologic. Okay, so now I have the timing and I have my grade. And right now in those 3 steps, I've collected a great deal of information. Let's go ahead and refine that information a little more. The 4th step is a very simple step. Are there any clicks? Are there any extra sounds? If there are any clicks and extra sounds, then it will be here. Extra sounds or clicks would be pathology. If there are no extra sounds, no extra clicks, then I don't have a problem. Let's go on and refine our findings even more. I'm going to look for splitting. And splitting is basically when you have, it's usually with the S2. You have S1, S2, S1, S2. It's related to the expansion of the lung. In many cases, it's physiologic. But if there is a consistent splitting, then it is pathologic. Normal sound would be tuk 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 tuk. In the case of a child, it's going to be a higher heart rate between 120 to 160, so it's going to be tuk 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 tuk. And if there is splitting, it will be tuk 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 tuk. There's a doubling sound, and with higher frequency, because it is a small body, it's going to be tuk 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 tuk, and that would be pathologic. And as you have realized, they're very close, they're very similar sounds, so it needs a little bit of practice. But if you are intending to hear it, if you're intending to look for splitting, which is why we're putting it as a separate step, you're going to do just fine. You're going to find it. So I'm going to say none, but really it's about inconsistent splitting. It's not there with every beat. And here it's positive, and that would be pathologic. And let's go on and change the position of the baby. If I change the position of the baby from supine to lateral to cubitus to prone, and here are different sides, and really, usually it needs just a small shift of position. The moment you shift the baby just a little bit up, the sound might change. If the sound changes, that tells me it is functional. It's not anatomic. And so you'd say there is positive change with change of position. That would be normal. If there is consistency despite change of position, then that is pathologic. And those are the key information that you're going to need to understand whether I have an innocent or a pathologic murmur. Now, I want you to go ahead and know a few statistics. About 50 to 80% of children at some time in their lives, they have an innocent murmur, sometime during their childhood. But if we're looking at birth immediately, then we have about 8 in 1,000 positive murmurs in live birth, of course. Okay? Let us talk about how functional murmurs are possible. I promised you to explain to you the process that happens between the transition of fetal and adult circulation. Let me talk about the major key differences immediately then and there. The fetal circulation, we have a shunting of the deoxygenated blood. And in the opposite case, we also have a shunting of the oxygenated blood, meaning in the adult circulation, right heart, lungs, left heart's body, right heart, lungs, left heart, body. In the fetal circulation, I want to shunt the lungs because I don't need them because I already have oxygenated blood, and that would be shunting of the oxygenated blood. And I'd like to also shunt the portal circulation, and that would also be oxygenated blood. But I'd like to also shunt from the right to the left through the atrial septal defect, or which is not defect before birth, the foramen ovale, and that would also be shunting of the oxygenated blood. And I also want to shunt the deoxygenated blood by returning it to the superior vena cava from above, and immediately goes both ways through the atrial defect and to the left heart. Let me discuss that in more detail, especially to explain the deoxygenated blood shunting. Okay, so ductus arteriosus is my major deoxygenated blood shunting mechanism. Blood comes from the superior vena cava, and the brain is a highly metabolic organ. The upper limbs, they have taken enough of their blood, and now they're returning purely deoxygenated blood, which mixes from oxygenated blood coming this way and goes in here. Notice that the pulmonary trunk kind of also does this. There is the shunt, immediately to the systemic circulation. And if you look, there's a change of color here that shows me the difference between purely oxygenated that comes here and there. Blood that comes through the ductus venosus has a preferential passage through the foramen ovale that immediately goes to the right heart. So there is a pulmonic shunt, completely ignores the existence of the lungs. The lungs, of course, don't even help it, and you might ask yourself, but how? Why is it going there? Why is it not going down? Why is it not going to the lungs? Because the lungs are not open. So there's a level of stagnation here and a slighter stagnation here, but at least there is a little bit of flow that is possible through the ductus arteriosus. The lungs are collapsed. But not only are they collapsed, they're extremely highly vascular structures, and they're just receiving blood like, about 3% or so of all of their capacity. Say 10%, but it is 3%, right? Say 10% through the bronchial circulation. Why? Or from where? From the right heart. And that's only keeping the lung growing. But all that extra vessels that are growing to make for the future oxygenation possible during adult life. Look how the lung here is bigger than the heart, and the lung here, which if we're considering on the same day of birth, right? This child is going to be born today on December 15th. Before birth, this is how the lung looks like, very small, and after birth, it's bigger the moment it expands. Okay, and bear with me, I'm saying a lot of things, but in a bit, I'm going to ask you to get a pen and paper and write very clear steps that's going to make fetal circulation and adult circulation and the transition piece of cake. Okay, so now we understand what's happening. Well, tell me about the transition. The transition is taking that to this. There are three major areas that I want to act upon. My ductus arteriosus to become the ligamentum arteriosus, my ductus venosus to become the ligamentum venosus, my foramen ovale. And those are the areas that I want to close. But then I also need to expand. It's not only about closure, it's the whole process. I need to expand the lungs. Imagine the lungs don't expand well because there's lack of surfactant. Then you should not expect that this will close because you still have resistance and you still have lack of oxygenation, which means that your renin-angiotensin system is active, which is also associated in relation to prostaglandin A and prostaglandin E, which are all vasodilators, which is why, by the way, as a note, if I want to keep the ductus arteriosus open in cyanotic heart diseases, I infuse prostaglandin E1. Okay? Carrying on, I also need to expand the hepatic vessels. I need lower pressure in the sinusoids of the hepatocytes or the portal system to expand and to suck blood in that area, causing a decrease in pressure in the ductus venosus, and similarly suck all the blood in the lungs, causing a decrease in the ductus arteriosus resistance. And that and this are going to immediately start to collapse. Notice, they say, with the first breath in life, there is a closure of the ductus arteriosus and then ductus venosus. That is not extremely accurate. It's a functional closure. Anatomic closure takes anywhere between 3 days and months and 3 months. but usually within the first week it happens. And when I say first week, I'm talking about clinical anatomic closure. It's clinically significant, but complete closure takes more than that. It takes about 20 days or something like that. Okay, and I'll show you that in a bit in an old article I digged up on the net. And so with the expansion of the lungs, I also have an added value, which is more oxygen. If I have more oxygen, the body immediately responds with decreased dilation of all the vessels because I have more oxygen. And notice the fetal circulation, it's got fetal hemoglobin and it's got high concentration of hematocrit compared to the adult. So it needs a little bit more oxygen and the bloods just simply stop dilating. They don't need all of that dilation. And that means a cessation of the prostaglandin E and prostaglandin A systems, which means further augmenting this initial reaction to cause a sustained functional closure until anatomic closure ensues after that, and reorganization through the childhood. Through childhood eventually causes the ductus arteriosus and ductus venosus to become ligamentum arteriosus and ligamentum venosus, to make them completely fibrosed. So that you see that there is a transition, and that process takes a few days. You know what that also means? That means those few fun facts. It means my pulmonary trunk isn't wide enough. It means that my pulmonary vessels still need to dilate more. They're still getting used to pumping a lot of blood through them. It means that my systemic circulation resistance is starting to increase, which means that the the arteries become more and more muscular. And this also a process that takes time, and hence, ergo, it means that those vessels at that period of time can give us functional murmurs, because a pulmonic murmur can be heard at a certain area, and it's simple because it's there because pulmonary vessels are not as dilated and we're still early and they're not completely developed. Therefore, although the circulatory systems develop in the embryo between 3 to 8 weeks during organogenesis period, final maturation occurs after birth. Why? Because no matter what you do during fetal life, you're not actually having adult circulation. And to reach adult circulation, you need more growth, and it actually happens. There's an actual growth, there is actual neovascularization. At some points, there is removal of vessels at certain other areas, and there's dilation, there is muscularization, and so on. Now, making that clear, I would like to go ahead and just make a final point before we end this little lecture about murmurs. This is an article I found from the Archives of Diseases of Childhood in 1966, December of 1966, so many years ago. And it says something interesting. The postnatal functional closure of the ductus venosus appears to be a consequence of a decrease in pressure in the portal sinus, resulting in retraction and narrowing of its origin, which thus assumes a slit-like appearance. This closure is probably reinforced by the muscular elements in the wall of the portal sinus near the origin of the duct. The functional closure of the ductus venosus occurs during the first minutes after birth, is not complete. An appreciable amount of the portal venous blood is shunted through the channel during the first hours and perhaps days of life. The organic closure of the ductus venosus begins at its narrow origin with proliferation of the obliterating tissue in specially structured border strips. Closure is complete between 15th and 20th days, and that's the actual full anatomic closure. With that, I hope that you enjoyed this lecture and that it was beneficial enough. Thank you for watching.